Most of the participants were aged 24 to 45. Over half of them lived in refugee camps, and more than 90% were unemployed. Now, I'll say just one thing, that we're speaking about the mental health of Palestinian women in Gaza, but it's important that this is an issue that is not only limited to Gaza, and there is intergenerational trauma that has occurred, whether it's from the Nakba or from the ongoing occupation, whether it's a result of forcible home invasions of civilian homes in the West Bank by the Israeli military, or home demolitions, or the impact of being forced to travel and undress in order to access basic medical care. And I will let Dr. Abu-Jamei take it from there and speak about the results of the study. Thank you.
Thank you, Dana. Yeah, Dr. Abu-Jamei, the floor is yours.
Thank you very much, Anna and Distant. Let me begin by thanking the organizers for this opportunity. And perhaps to begin with, over the last 2 days, we were following news that were coming from Jenin camp, where Israel was having a military operation that ended with, I think, more than 10 people who got killed and several hundreds that got wounded. Now, to us people in Gaza, that brought some unfortunate memories, actually. Most of the people recall what happened in 2014, and to a lesser extent in 2021. I talk of the scenes of women and children who were leaving their houses in the middle of the night, going to seek shelter outside of the camp. That is something that really happened in 2014 with more than 500,000 people who left their houses during the attacks that continued for 51 days. And when they returned, when things stopped, they came back. More than 100,000 people didn't find their homes to return to. There were, I think, more than 16,000 residences that were completely destroyed, and tens of thousands that were partially destroyed. The figures that come from Jenin are quite lesser than that, but to us, people in Gaza who have experienced this, 26% of the population, imagine the 2.3 million people, 26% went through that in over 51 days in 2014. And in 2021, another 100,000 had to leave their houses also. And just to give you another idea of why we have such, let me say, recollections. Another story is the map that I'm going to share with you. This is a map. I hope that, let me try to make it clear. Okay. So this is a map of Gaza Strip. This is a small geographical area that is, about 40 kilometers in length and about 8 to 14 kilometers in width. You see a lot of blue squares, and then you have smaller red, green, and yellow squares. These were made after the May 2021 attacks on Gaza Strip. It was made by a UN organization called UNITAR. The blue squares are the facilities, like health facilities, schools, and other facilities. The smaller squares are the bombardment areas. So the greenish ones are the less bombed areas. The reddish ones are the most severely bombed areas. If you look at the area in Gaza and northern Gaza, you will see a lot of blue squares, which is a lot of facilities, which means a lot of populated areas. And then you will find that the attacks are more spread everywhere and even more dense and more reddish, which is mean more, destruction. If you look at these areas, a little bit to the south, the eastern area of Khan Yunis, this is the widest area. And Khan Yunis also the very eastern side attacks. Now, those attacks are mainly aerial by the jet fighters, but sometimes it comes through artillery to the neighboring areas to the separation and defense. And that's why when we look into the post-traumatic events, the levels were really high when it comes to those women. More than 400 women who were screened and interviewed between March and December 2021. That's about 2 years ago. The most frequent event reported, I mean, that people were exposed to, those women, was the continuous, loud, severe buzzing noise of the Israeli drones. That's 98.8%. Now, those drones operate almost 24/7, and the in the evening, the noises are really harder and harder. I mean, higher and higher, and you can easily get irritated by them. Residential area has been bombarded. That's 91%. Movement restrictions, 83%. Difficulties in providing requirements and the needs of a decent life for themselves and their families, 82%. About 35% of those women experienced loss of a family member during the Israeli attacks, and 31% were injured during an Israeli attack on Gaza. Now, this the sample, the 400 and more women, these were women who live in the most marginalized areas in Gaza Strip, because the project, as Dana said, tried to attract, to target the most affected populations. And that was through the mobile clinics that offered both physical support, physical intervention, and psychological intervention. So that may be also another reasons why we have about 31% of those women who got injured during the Israeli attacks on Gaza. 72% or 70.2% were unable to access the vital medical care they needed due to the restriction on freedom of movement. 35.7% lost a sick family member who had not received their support, their help, their health because of the not receiving the exit permit in a timely manner. Now, the exit permit is another issue. Palestinians who need high-level intervention, medical interventions, the Gaza Strip is not that much developed when it comes to medical health interventions. So a lot of that tertiary and fourth-level interventions have to take place outside Gaza Strip. And this happens through referring people to either hospitals in East Jerusalem or in West Bank. Now, a lot of those people are cancer patients, people who are in dire need for delicate operations, and kids. And unfortunately, it's not quite few percentage of them, they do not receive their permits in a timely manner. About 1/3 of the participants participated in the Great March of Return, and this is something that we can talk a little bit about later. Now, one would say, what would be the psychological impact on those people when we have the level of exposure such high? It's another, also, it's not a single time. We speak about frequent exposure. The recent attacks were like 2 months ago. In 2022, we had another one. In 2021, we had another one. And then 2014, etc. The prevalence of psychological distress, anxiety, depression, and stress was about 64%, more than 64%. That's 2 in 3 women. 26.7% had moderate psychological distress, but 47.6% had severe psychological distress. If we are going to add moderate to severe psychological distress, we will end up with more than 73%. 71% of the participants, when they were screened, they are potential cases for depression. Potential cases for depression means that they need further follow-up by a clinical, by our community centers in order to check whether they have clinical depression or not. 80.9%, they have the potential of having an anxiety disorder. Now, we looked into what are the main predictors to mental health. The main issues were violations to the right to life and to the right to health. These were the main components. Of course, we looked into the other predictors of mental health, but these were the main ones that affected negatively those women. The right to life, the general one, just to live. and then the right to health. Finally, this is a community that has a lot of resilience. And the question was, what coping strategies Palestinians have in Gaza Strip, those women? And a lot of the coping strategies are simply quite expected. Anyone who is stressed will seek something that will divert him from or her from the challenges that they are facing. Mrs. M, this is a 45-year-old woman from North Gaza, said she used to deal with stress by going to the sea with her children. She said, I take my kids and go to the sea and sit on the beach at the sunset. This is very nice, wonderful. It's one of the coping mechanisms that women use. And we all the time say we are lucky to have the sea on our west side. We all the time say it wouldn't be really livable. Sorry, not livable, by the way, but it wouldn't really be livable if it's a mountain rather than a sea. Focus on the positive aspect of things, like you really celebrate what's left. Miss S from Beit Lahia said, Alhamdulillah, thank God, who saved me and my children during the attack, and that what happened to us was trivial compared to the others, because people compare their losses to the others. So you're thankful to God that you were not as affected as the others. Ignore the problem. This woman was simply distracting herself with household chores and cleaning. Just let's do something positive. And then there are the other three things: seek spiritual support, seek professional help, and also social support system. The social support system is the most important, according to our various research studies. This is an area that a lot of people get help through their nuclear family members and through extended family members, and we think it's the main source of resilience when it comes to Palestinian people in Gaza. So this is all what I wanted to say. Thank you very much for listening, and I look forward to the discussion.
Thank you very much, Doctor. Fidaa, the floor is yours. Let's first move on to you before we move to the questions and comments and reactions.
Thank you. Thank you for everyone who's participating, for taking the time and interest to attend. As Esther said in my introduction, I'm currently working with Oxfam, but I've been working in the humanitarian and human rights sector for the last 16 years. And aside from that, I've been born and lived in Gaza my whole life. I'm a mother of 6 children. And I want to start off where Dr. Yasser left off as he was describing the coping mechanisms, because it struck me as they're not working for me. Like when he was presenting them, I was thinking with the counter coping strategy, because I've been through all of these coping strategies trying to do them. So the sea, when you go to the Gaza Sea and try to enjoy a sunset, for example, as a coping strategy, for me, I've come to call it our sea. Because from my personal experience, I've been out of Gaza, out of Palestine, I've been to Europe, to the US, to Turkey, to different countries in the course of my career. And the first thing that struck me when I went to a coastal place is how I see their sea, and how I came to call it our sea, because I came to realize that it's a closed off sea. You can't go diving in that sea. You can't do surfing, can't do water parachuting. You can't do any kind of water sports. You can't simply take a fast boat or whatever other entertainment that are available everywhere else when you live in the coast. And when you say to someone that I live on the beach, like my family's house is right on the beach, but what does that mean? It doesn't, for me, it increases the crisis. It increases the feeling of imprisonment and living under restrictions, because even the open sea is closed off. Like when I look at the sea, I see everything that I cannot do when I go to the sea. When we say focus on the positive, what's the positive? That your life is spared. But when it's you, when as I said, I'm a mother of 6, I keep thinking of the lives of my children. And is it gonna be spared next time? Are we gonna be spared every time? Are we gonna get lucky every time? Like this keeps repeating every time there is an attack, there is an escalation, there is some events, like are we gonna survive it? As a recurrent question, and I'm sure it's recurrent in every mother's mind as well. When we try to distract ourselves with work, for me, work is not a distraction because I work with the problem. And in the course of my work, like I interact with people who I might be in their place at any time, at any moment. So this keeps also playing in the back of my mind. I think of people as our target groups, as the communities we serve, but at any moment, the roles could be reversed. I could be this targeted group. My kids at home could be a targeted group while I'm at work trying to respond in an emergency setting, for example. So this is how it's, for me, like how it plays out in my head all the time. When I started talking about comparing contexts, as I said, for the restrictions or for living in an imprisoned, sieged, blockaded, small place as Gaza, my first time to manage to go out of the country, I was 35 years old. And it was my first time to be able to travel. And it was very strange because I kept telling myself, I should have experienced this so much earlier in life. I should have experienced to go on a plane much earlier. I should have seen this or done that much earlier in life. So even if you go out of Gaza and you are lucky and privileged and working in an international or a UN organization, these are the requirements or what it takes, and not always, of course, that you can get out, step out for a very brief time out of this prison. It's not a solution. It's very temporary. And what it does to you is that it brings you sharp awareness of what you're missing, of what should be done and how you should live. And when you get back to that prison with all of those comparisons in your mind, it's very difficult. For me, on a professional front, as I said, I've been working with women, with children, with communities who are suffering, whether in emergency settings, in emergency responses, or in the course of normal humanitarian situation. And for us as an organization, we do also face so much challenges. Challenges, of course, of structural and organizational problems, but also when it comes to mental health, the prioritization of mental health for organizations who deal with very huge needs and gaps. And when you try to prioritize, it's very difficult to put first and foremost mental health. Sometimes when you are faced as an organization with a choice or with a question, do I feed hungry people? Do I save lives that are of people living under fire? Or do I care for their mental health, for example? I know this is not a question to ask. There is no question of the priorities, but when you are forced with limitations in resources, limitations in donor perspectives, limitations also on access to what it takes to work on and mental health, it's a real question, and you have to make a choice. You are forced to make a choice. And for me as a humanitarian practitioner, this means that all of the humanitarian response that you are providing is missing an essential part. Because again, I go back to the coping. When you save the lives of people under fire when you provide them with food, when you provide them with cash, with access to services. You create this state of stability, of meeting their basic needs, that they start thinking of the mental health aspect. They start questioning also away from the humanitarian response, when not all of people of Gaza suffer from humanitarian difficulties. Yes, most of them are, and they are a very real target to mental health issues, but some people live in a good situation. I am an example. I have a stable job. I work in an international organization. I own a nice house. I have a car and kids, and all of the elements that if I'm in somewhere, if I live somewhere else, would make a great life. Why would I be stressed? I'm stressed because I live in Gaza, and I live in Gaza is a very packed phrase. To unpack it, sometimes you have maybe to write books. I know it's very hard to convey what it means to other people living outside of Gaza. It's very difficult for us even to make sense of it at sometimes. Sometimes you are escaping from the very fundamental existential questions to be able to continue your day-to-day life. Sometimes it's very difficult to deal with what Dana earlier called the generational trauma. We inherited generational trauma as women living in Gaza from very long years of occupation and siege, and the lives of the people who came before us. But it's very heavy to think of how you are transferring or not transferring that to the upcoming generation. My eldest child is 14 years old. So she was born in the blockade. And a very maybe simple, fleeting example is I was talking the other day to them, and I was saying, like, before we had electricity cut problems, and they were like, what are you talking about? Are these tales that you're telling us? There is no such thing as 24 hours of electricity. They don't even believe it. And if you say, at the time when Gaza was open for people to come and go, and they were like, are you telling us tales, So a whole generation is born under this context, and the changing the narrative is going to be much, much harder than changing our narrative, because at least we know the before and after. For the next generation, there is no before. It's all the same. Imagine being born in a prison and trying to convince them that there is another reality. There is a different word. There is something wider and more to this word. I think this is the main challenge that we have to face. And again, it's a question of, as you said earlier, of not having mental health as an afterthought, as an accessory. It's not. It's very essential to everything that any organization is trying to do. And that takes me to my final note. As Oxfam, among other organizations, and as the reason or the logic approach says that a main ask is it doesn't happen on individual basis. I know individual faith maybe of the justice of what we ask for is essential, but a collective, meaningful political action is what is needed to end this illegal blockade, to end this occupation, to end the root causes that jeopardize and compromises the mental health of millions of Palestinians living in Gaza. Thank you.
Thank you very, very much for these insights and for also sharing your personal story. I have a lot of questions, and we already have some questions that are coming in. I will start with my question because it's also a question I saw one of the audience members raising. And that is if you, and then I'm kind of like speaking to all three of you, could say something about the extent to which it's accepted to talk about sort of mental health in Palestine, because I'm Dutch, and I would say that it's only been a recent thing that more and more people are starting to talk about it, and that it's more and more socially accepted to actually actively go out and ask for help. So I was wondering how that is, what the situation is in Palestine, and specifically in Gaza, and also like how difficult or how easy it was for you to find people to openly talk about this as part of your research, for instance, but also like how, if you feel like people easily come to your clinic to ask for help, or if you need to go out to actively like ask people for like, hey, this is something we offer and it's something you should make use of. So yeah, if you can say something about the sort of the culture and the extent to which it's socially accepted, let's say, to talk about it and to ask for help. I guess I would start maybe with Dr. Abu-Jamei. And then if Dana or Fidaa, if you would like to add something, like please feel free to immediately just step in.
Yes, thank you, Esther. This is a very important question. When Gaza Community Mental Health Program was first established in April 1990, we had 0 referrals from the community. There wasn't a single case that is self-referred. And almost all the cases, actually all the cases were coming because they were referred by a physician. So people were going to primary health care or to health facilities, and then they were instructed to go to see a psychiatrist or a mental health therapist. And that's why since even we began, we understood the importance of having campaigns that would really deal with the stigma and educate the population, because these are extremely significant and important issues. Now, this was part of all our work that we were doing. At the moment, we have 3 community centers. We have been educating the public at large for the last 3 or more decades. And at the moment, about 70% of the people who come to seek our services are self-referred or family referred. The other 30% are referred by a mental health, mostly a physician. Now, this is one part of it. Mental health stigma depends actually also on the theme, the content of the issue, the complaint itself. For example, when you go to Gaza Strip now and you talk to people, almost everyone will talk about that. Maybe they will not talk about the details. Maybe they will be traumatized. Maybe they will try to avoid the details, but they will speak about the stresses. That's something that everyone talks about without really constraints, almost everyone. Or if you have women, or if you have children who are suffering, then it gets more complicated. It gets really more complicated. When it comes to problems like with psychotic patients, it gets also more and more complicated. People tend not to speak about such issues and not to really go to seek mental health services. Now, this is one part of it, where they can find mental health services, and the importance of this research, whether we face some difficulties or not. All the participants, not all of them, about 2/3 of those women were met in the health facilities in their vicinities, in their neighborhoods. Okay, only about 1/3 came to our mental health centers, and they were talking openly. And I don't recall, maybe just quite few women who didn't really come to. Just quite few women who really didn't respond to the questionnaires that were distributed, but most of them were really cooperative, and most of them were talking about their difficulties. And that's why it's important when we speak about mental health services to be aware of the marginalized communities. The conditions in Gaza Strip are very dire, the economic conditions. We have 3 community centers, but we had another 5 community-based organizations where we send a psychologist every day, because that service will be more, or is more, accessible to people. We have one in Gaza City, we have one in Khan Yunis in the south, we have one in Deir al-Balah in the middle. Those are the 3 community centers. We have multidisciplinary teams, But then we send the psychologists to 5 areas, like the very northern areas, the very southern areas, and the very eastern areas, paying 1 or 2 shekels to go to the center and come back sometimes is a burden that we need to think of really a lot. And then it becomes a lot easier for women and for children to come because they are going out for a community-based organization. No one really would notice that they are coming to a community mental health or a psychiatric service. So you need to keep that in your mind when you work. This is one of the key issues. The other key issue is just to continue the campaigns. It's never enough to combat and fight stigma. It's never enough. So I think I covered this. Who provide mental health services in Gaza Strip? 3rd level services when it comes to therapy, when they have psychiatrists and they have medicines, drugs, medications. We have only the Ministry of Health and the Gaza Community Mental Health Program. Ministry of Health has 6 community centers. Gaza Community Mental Health has 3 community mental health centers. Children are more capable of receiving treatment at the GCMHP because we have more skilled staff and we have play therapy rooms in each community center. And we were doing that for the last 33 years. When it comes to women, it's all the time an issue whether to go to a public health facility or to go to an NGO. You will always find NGO like more private, ensuring more privacy, more confidentiality, etc., etc. There is another question, but I'll leave it later because maybe Fidaa or Dana would like to add something.
Yeah, actually, I just want to add one more personal insight to your question. There's the element of guilt when you are even aware of the importance of the mental health services or the importance of asking for help when you feel that you're suffering. For me, I experienced this personally, and this comes from someone who's been working in the sector for years, and from someone who originally studied psychology and worked as a psychologist for 3 years at the beginning of my career. I know the importance and I realize it, but the access to that service, there is an inherent guilt associated with asking for help. And I know this is the case for many women. Like, is it really a priority? Is it really needed? There are much people, as the woman that Dr. Yasser mentioned, to say like, we were spared, thank God we are still alive. It comes to you that I'm still alive, my house is still standing, my kids are fine. Why would I need mental health or psychosocial support? This is like being spoiled, or you're feeling that you're taking the right of other people's, especially that the needs are so huge and the available services are so little to address them. So there is always in the back of your mind when you try to ask for sexual support or services that there are people who need this more than I do. And as strong as this social stigma is, this internal sense of guilt is a huge barrier as well that would stop especially women from reaching out and asking for psychosocial or mental health services.
Thank you. Thank you all. I am trying to select from the questions that we have because we only have 15 minutes. So maybe we have one person that is asking a question. I will read it out loud. The person says, I can imagine that the situation in Gaza increases domestic violence because of like the stress and constant anxiety. And so the question is domestic violence also one of the causes of mental health problems for women?
Yes. Domestic violence increased over the last years. And we also noticed, we don't have really a research, but we have noticed an increase of domestic violence during the COVID-19 time, during like 2019 and 2020. And we have noticed also an increase in domestic violence during and immediately after the large-scale military operations that take place in Gaza Strip, you know. So it's there. Imagine in 2014, for example, more than 100,000 people got stuck in 50 schools. You know, on average, there were 2,000 people per school, and these were mainly called the shelters, which was just an normal school. So imagine 2,000 people, mostly women and children. They are, of course, exposed to violence, including gender-based violence, sexual violence, harassment, etc., etc. So the short answer is yes, and I think Dana can add to that.
Yes, if I may, I'll just add that, you know, the focus in this project was to show the linkage between, you know, the political context of human rights violations and mental health. And I think that also applies to domestic violence. Of course, you know, we know from international studies that domestic violence increases during situations of stress. And it's not, you know, we understood that during COVID-19, whether it's, you know, in the Netherlands or elsewhere, that there was more cases of domestic violence and child abuse, etc. So yes, domestic violence is a contributor to the mental health of, you know, Palestinian women in Gaza, but domestic violence itself is not only attributed to, but also influenced by Israeli human rights violations. So I'll just want to emphasize that.
Thank you. I have another question, which is about the blockage. Because, like, of course, like, I mean, this applies to all of Palestine, but we're for this webinar specifically zooming in on the Gaza. So to what extent does the blockage harm you or like prevent you from providing proper assistance? If you can say a few words about that, or if yeah. So apart from the fact that there's, you know, obviously like the constant violence and the violations in terms of like the service or the healthcare that you want to provide, is there a specific sort of impact on that? Sorry, I think maybe shall I like appoint people, because otherwise Ms. Alaraj, can you start?
Yes, where do I start? Actually, the impact of these barriers, or the whole contextual structural barriers that we operate in, to us providing, being able to provide services or reaching the people in need, I would have to talk about maybe two main things. As I said, need and the limited capacities that we have as organizations. And the other thing is how to select or how to prioritize how to support and who to support and when. So, for example, you as an organization, you support in the normal course of things in the different humanitarian sectors. And suddenly imagine that you're working, you have a plan, you have a team, you have some resources allocated, and you have a plan to reach this number of people or this vulnerable community or targeted group. And then there is a peak or an escalation, a peak of violence, an escalation, an incident. And so now you have to stop your normal operations and respond to the aftermath of this emergency, and then bounce back to the normal, which is not normal to begin with. This dilemma is one of the main barriers to us being able to provide support or services or being consistent. When it comes to mental health specifically, this deprives us of accumulating impact. Like you do a lot of work, but the impact is reduced by these recurrent escalations or emergencies, and your recurrent stopping of services. So you have to start from scratch or going back to an earlier baseline. And also you have to deal with the accumulative impact of the crisis with decreased capacities. It's very complicated when it comes to normal humanitarian assistance. When it comes to the mental health or psychosocial support, it gets even more complicated. Another aspect is how to combine, how to integrate the humanitarian assistance with the mental health, how to provide complementary services, which is not always possible due to different challenges. So we are always thinking of these questions. It's not a one-time answer and khalas, you continue work based on that. There is no fixed knowledge, no fixed answer to this. You have to keep asking and keep seeking answers, which is not an easy job to do. I hope this answers a bit of your question.
Yeah, of course. And I mean, I think for all of these questions, like we can organize a separate webinar, right? Because these are all like massive topics that are impossible to answer in like 2 minutes. I have selected a final question. I think it's a question to ask to all three of you. So maybe we can stay with you, Fidaa, and then we move on to Dr. Abu-Jamei, and then we move on to Ms. Moss. The question, I will read it out loud. Thank you to all of the speakers for sharing your experience. What do you feel is needed, or what can be done by the international community to help improve the situation? For instance, what would be the 3 things that need to change in order to help improve the situation of mental health in Gaza? So also remember that you're speaking specifically to more of like a humanitarian audience at the moment. We have a few policymakers, so it can be a little bit of both, you know, like both policy, but also like how can NGOs support the situation? So 3 things that need to change to help improve the situation of mental health in Gaza.
So I would start with the obvious. As I said earlier in my comments in the chat, it's a cycle. Mental health is related to everything that we live. It's not a mental health condition rather than a chronic life condition when it comes to people living in Gaza. So we need to break the cycle to be able to make any progress in the mental health. Break the cycle meaning addressing the root causes, and the international community is the best positioned entity to do that, to place pressure on Israeli authorities, on the occupation forces, to lift the blockade on Gaza. Lifting the blockade would mean more accessibility to women in need of a treatment. As Dana spoke earlier, you have to go through super humiliating procedures if you are guaranteed a permit to go and take the basic need of a medical treatment, for example, outside of Gaza. You will be able to move without restrictions. You will be able to have medicines in Gaza, important, including mental health medications. You will have the ability to have expertise, international or external expertise that are very much needed in Gaza to be able to support the people. So this is number one. You will be able to stop the recurrent peaks of violence or the escalations of violence that are one of the main triggers or root causes of this mental health issues. The other thing that the international community is well positioned to do is to try and influence the donor community to recognize the prioritization of the importance of prioritization of mental health, to include it or to consider it at the core of the humanitarian support. It is a humanitarian basic need. It's not a developmental need. It's not a luxury. It's not something that only first world countries are at liberties to ask for or to wish for. It is a basic humanitarian need that needs agendas of humanitarian donors and prioritize in their funding schemes and the plans. So this is a very important thing that also can be done.
Yeah, I think one of the most important things we need to keep in mind is the problem with unemployment and the problem with poverty. Over half of the population are under poverty rate, 1/3 under deep poverty rate. We speak about 1 million children living in Gaza Strip, half of them, 500,000 children, live in families under poverty rate, and with that comes a lot of problems and a lot of concerns. So fighting poverty is an important issue. And with that comes unemployment. Unemployment rate is about now 46%. It went up to 53%, I think, a couple of years ago. More than 70% of the people below the age of 30 are unemployed. People in Gaza Strip are educated and entitled to work. Most of them are university graduates, by the way. So the job opportunity and the fighting poverty is one of the top things that we need to have. And these are one of the main issues that affect mental health. Second, the right to movement. And under the right to movement goes a lot of things. Students who need to continue their education abroad, mental health therapists, physicians, healthcare workers, all of the other skilled people who need to go abroad to attend conferences to get their to get a higher education or to get more skills. They have problems with the right to movement. Patients who are in dire need to receive treatment in West Bank or in East Jerusalem, they are entitled to receive their right to movement. Right to movement is a basic human right that should be respected. Third, we are people who are living under occupation. There are international laws that need to be respected when it comes to people who live under occupation. Let's begin from there. If you are not capable of ending the occupation, then please let's adhere with the international laws that control how an occupier need to be dealing with the persons that live under occupation. These are the three main things. Thank you very much.
I will just add two last things. I think, as humanitarian organization, sometimes, there's a wish to sort of separate humanitarian from political work, and there needs to be an emphasis that this is a political problem, as my counterparts have said, and as Yasser said, there is international law. For us, you see the situation is that of long-term occupation as a regime of apartheid, and of course there are precedents here, and they should be followed. Thank you, and thank you all for listening.
Thank you very much to all three of you. It's 5 p.m. sharp Palestinian time, 4 p.m. European time. So we already have to end it here. I just wanted to remind everyone that in the chat, there is a PDF file with more information. If you want to read more on the research or find like a summary, and you can also find the contact details of Dr. Yasser and of Ms. Diana Moss. I see you already put your email address there as well. So yeah, please reach out if you have questions, if you have information, comments, whatever. As mentioned in the beginning, this webinar was recorded. So for those who are interested, you can always look it back to get, to refresh your memory a bit. We will post it on our websites. Yeah, so thank you very much for your time, everyone. Thank you to all the speakers for sharing your experiences, personal story, and good luck with promoting the research as well, and trying to bring it to the attention of as many policymakers and humanitarian aid workers and international actors as possible.
Thank you. Thank you all.
Thank you. Thank you everyone for listening. Have a nice rest of the day.
Have a nice rest of the day. Take care. Okay, bye.
Bye-bye.